Today we will be discussing about Parkinson's disease. It is a chronic, progressive, neurodegenerative disease characterized by degradation of the neurons that produce dopamine in the brain. It is more common above the age of 70, and it occurs more in men than women with a ratio of 1.5 to 1. The cause of Parkinson's disease is unknown, however there are many risk factors. The genetic risk factors involves Parking genes including SNCA gene, UCHL1 gene, PINK1 gene and PRKN gene. The first two are inherited autosomal dominantly, while the last two are autosomal recessive. The environmental risk factors suggest that head trauma, well water, pesticides, heavy metals and air pollution exposure increases the risk for Parkinson's disease. The idiopathic form suggests that oxidative stress from dopamine breakdown causes degradation of the neurons. The idiopathic form is the most common cause in practice. Now let's move to the pathophysiology of the disease. This part gets very confusing, so I want you to follow very closely. This is a diagram of the brain and the location of the parts that are relevant to the disease. Let's discuss the physiology first. From this diagram we can see the substantia nigra. The substantia nigra is in the midbrain and it is divided into two main parts, the pars compacta and the pars reticularis. The pars compacta, also known as the SNPC, contains dopaminergic neurons, while the pars reticulata, or SNPR, contains GABAergic neurons. Next we have the cerebral cortex and the basal ganglia. The basal ganglia is a group of nuclei that regulate movement. It is made up of the striatum, globus pallidus, subthalamic nuclei, thalamus and even the substantia nigra. The striatum contains the caudate nucleus, putamen nucleus and nucleus accumbens. The globus pallidus contains an external segment or GPE and an internal segment, GPI. Then we have the thalamus and the subthalamic nuclei. The cerebral cortex sends excitatory signals via glutamate to the striatum, and the substantia nigra pars compacta send both excitatory and inhibitory signals via dopamine to the striatum. Dopamine excites the D1 receptors in the striatum and inhibits the D2 receptors. D1 receptors form a direct pathway of stimulating the thalamus, while the D2 receptors form an indirect pathway that inhibits the thalamus and movement. Dopamine causes movement by exciting the D1 and inhibiting the D2 receptors. D1 receptors inhibits the internal segment of globus pallidus. Globus pallidus, which sends inhibitory stimuli to the thalamus, has been inhibited. As a result, the thalamus can stimulate movement by exciting. Conversely, D2 receptors inhibits the external segment of globus pallidus, and the external segment of globus pallidus cannot send its inhibitory stimuli to the subthalamic nuclei. The subthalamic nuclei sends only excitatory stimuli to the internal segment of globus pallidus, causing it to increasingly inhibit the thalamus. This results in inhibition of movement. This is the normal function of the brain. However, in Parkinson's disease, there is reduced amount of dopamine released from substantia nigra. This leads to reduced excitation of the direct pathway that stimulate movement and reduced inhibition of the indirect pathway that oppose motion. The cardinal features of Parkinson's disease, with a mnemonic called TRAP, include tremors, rigidity, akinesia or bradykinesia, and postural instability. Note that only tremors, rigidity, and akinesia are early signs, while postural instability is a late sign. Tremors are described to be pill rolling, occurs at rest, with a frequency of 4 to 6 cycles in a minute or hertz. Rigidity is either lead pipe or cogwheel. Cogwheel rigidity is basically lead pipe rigidity associated with tremors. Akinesia is slowed movement which affects handwriting, causing micrographia or small characters, inability to button or zip upward, inability to blink eyes, and masked facial expressions. It is typical of these motor features to appear initially on one side of the upper limbs before spreading to other parts. Postural instability is a late sign characterized by a stooped posture. Frequent falls is a late sign of postural instability in Parkinson's disease. If falls appear early in the disease, consider other causes. Other motor symptoms include a shuffling gait, in which the person walks like the feet are glued to the ground. There is dystonia, meaning sustained painful involuntary muscle contraction such as foot inversion, akathisia, meaning restlessness, drooling, fatigue, hyperphonia meaning soft voice and dysphagia. For the non-motor features of Parkinson's disease, most of these are called prodromal premotor features, meaning they occur before motor features appear. They include anosmia, meaning inability to smell, depression, anxiety, REM sleep disorders, urinary incontinence and constipation. Other non-motor symptoms which appear after motor features include cognitive impairment and dementia. Mr. Squawk, an 82-year-old retired miner, presented to the neurology outpatient with a 12-month history of a right-hand resting tremor, associated with stiffness, slowness of movement. Manage him. Diagnosis of Parkinson's disease is mostly clinical. Ensure to take a good history. Ask about drooling, sleeping disorders, expressionless face and other typical features of Parkinson's. Also take a drug history of dopamine blockers and antipsychotics to rule out drug-induced Parkinsonism. Perform a neurological examination and check his gait to support your diagnosis. Investigations mainly exclude mimics and support clinical suspicion. In Mr. Squawk, PET scan shows reduced dopaminergic activity in the substantia nigra. MRI brain is normal. DAT scan confirms dopaminergic neuron loss supporting PD diagnosis. UPDRS score indicates moderate motor impairment. FBC and ESR results are normal. VDRL and HIV tests are negative. Copper and ceruloplasmin results are normal. Genetic testing show SNCA1 gene mutation. To treat Mr. Squawk, advise him about regular exercises and refer him to a physiotherapist. Speech therapy and occupational therapy referral may be done if indicated. Also, drugs that can be used to treat his motor symptoms include levodopa and carbidopa combination. Carbidopa prevents peripheral breakdown of levodopa. Side effects include dyskinesia and orthostatic hypotension. Dopamine agonists such as pramipexole A, ropinirole and rotigotine help to stimulate dopamine receptors in the brain. Side effects include hallucinations and orthostatic hypotension. They must be avoided in older and demented patients. Dopamine agonists are particularly preferred in young people with Parkinson's disease. Other drugs that can be used for motor symptoms include monoamine oxidase B inhibitors such as selegiline and rasagiline. We can also use amantadine, catechol-O-methyltransferase inhibitors like entacapone, and anticholinergics. If he is depressed, treat with SSRIs like sertraline. Avoid benzodiazepines as it may cause dementia and more depression. Administer melatonin for REM sleep disorders, fludrocortisone for orthostatic hypotension and laxatives for constipation. Thank you for watching. Please like, share, and subscribe.